When we work with kids, I apologize, I left nurses off. I'm in private practice, so I don't sometimes think. Okay, so nurses should be on there, definitely, and I will change that. The child, the adolescent, is our main patient. That is what we have to think first. Then we have to involve the parents around. Siblings, we often forget siblings. Sibling rivalry is very big often in this. We have to look at everything else what is around. Grandparents, we need to look at peers. They have to have somebody to talk with. Then we need to involve the schools. We involve our doctors, endocrinology, definitely. Then we psychiatry, psychology, social work, nursing, everybody who is in the team. That's the most important in gender issues. We have to have a strong team around these kids. When we work, the first thing we think it's harm reduction. We heard how difficult it is with a child. When we are torn, can we do that? Can we not do that? Where we go? And really what they want often is the recognition, who they are. When we give them the right medication to slow them down, they often take their time. As long as they are recognized, as long as we can talk with them properly. Informed consent, I see is constantly. People don't sign informed consent, so don't forget that. Steve pointed out, name is really important. Previously, we've played with Barbie and Ken, our famous gender dolls. Now, everybody is on the computer. Ask the kids what avatar they have, who they are on the computer. It's the best thing to find out. Gender kids are often using the opposite gender avatar. A boy might be a girl. And this 15-year-old one, what I talked there, who was Lady Gaga. I didn't know before, now I know who Lady Gaga is. That's the age then. So look who they are on the internet, as who they converse in their channels when they talk with other people. They often have their internet names as the opposite genders. When you open this channel, they are open book. They talk with you. You have the interest. Pronouns. Pronouns are important. If Mary comes in and she's really John, and you say constantly she gets tied up and she will not talk anymore with you. So watch that. Be open and talk about any reservations you have. Do not lie. Kids know that like this. If you make up a story, we have to do this or that, or we can't do that, they know. And automatically they will not come back to you, or they don't tell you the truth. And in diagnosing, there are so many books out now. She's Not There is one of the books. A transgender person really talks about their experience. The kids tell you exactly the story, what is written in there, and you want to hear. For what they want is the diagnosis and moving on there. That brings me to my first slide. I forgot something. Diagnosing kids. I do not like diagnose kids before adolescence. So I prefer to talk about gender variance. Children with gender nonconformity, not diagnosing. When we have the diagnosis, it sticks. The only gender identity disorder, when we look at it, when they transition, the diagnosis is gone. However, according to our good book, the DSM, we have the diagnosis until they have the final operation. Final operation, not everybody can afford. A male to female is $18,000. A female to male can come up to $60,000. So who has the money? So that's a problem. And that gives the number what Steve clearly showed and said. They are skewed for, we only have the numbers from who went through the operation. And definitely less female to male operations are than male to females. So that makes our numbers an issue. GID diagnosis when we go into puberty or right before when we start the puberty suppressant hormones or then with the hormone treatment, that's when we diagnose. And that's when we give the diagnosis. Yes, it is important. Even so, yes, I would like to see it out of the DSM. However, we can't afford it, for we need the treatment for these children. So therefore, we need the diagnosis. And in 2013, our new DSM will come out, and Steve said it will be some changes in there. Interventions, we need a proper assessment. We need to look at the GID assessment, we need to look at eligibility and readiness criteria before we go on hormones. The SOC is the standards of care, what the World Association of Transgender Health gives us, and they are really important that we follow them, for it will really help us and help the endocrinologists and the doctors to move forward with these children. We need to talk about gender identity, sexual orientation, and identity. Always these two things are thrown together. They are separate. They are two different issues. And kids, when they come, they talk about that. One reason is, when they are adolescents, hormones are high. Everybody is interested, and peers talking about sex. So these kids are not different. However, one problem comes there. If a male to female experiences sex in their puberty, it's great. Sex is something good. So why not? Hormones shoot up, good feeling. But with this, right away, it becomes right down, and they get severely depressed and suicidal. For the brain tells them really, why can be this feeling good? I know this part is wrong, and I feel good. So there is this conflict. And they get very distressed about it. So we need to talk about it and help them to understand what happens there. Self-acceptance, shame, and guilt is huge. We cannot start any treatment before the child does not accept themselves or the adolescents. That's the number one thing. With self-acceptance also comes the part of coming out, and it becomes the urgency of transitioning. And that's the dangerous thing. When this young teenager now want to go in school as Lady Gaga, you know, as a boy before, next day Lady Gaga, it doesn't go, we endanger this kid. So we need to talk about what is the urgency, what can we do to transition safely. There is little things what they can do. Put nail polish on in a dark, colorless. Nobody sees it. Let your nail grow a little bit. Have an ear pierced. You know, it decreases already the stresses, so we do little things. Maybe wear female underwear. Nobody sees under the pants. So get them out from the gym classes, for that gives them often great distress, changing room, or having to play football, what they don't like. So we need to help him through that. Urgency of transitioning is the safety. We need always to look at safety. Coming out and name change when we transition. And resources, Steve did some, and I wanted that you remember one thing. Evaluate your own transphobia. We all grew up in the gender binary society. We all grew up with a father, mother, with sisters, brothers, who really learned in their youth that transgender existed. So we have transphobia, everybody of us. We need to recognize it, work with that, and learn through it. Be non-judgmental, always work in teams, for I think that teamwork is the most important. We have to work together. If we delay too long, we increasing the risk for these children. And again, harm reduction. It's important. I want to leave you with a closing thought. I want that you remember the 3-4-year-old one who insists to be the opposite gender. The teen who comes in totally depressed, difficult to get along with, who talks about not fitting in. These kids might grow up to be the adult, the 30, 40, 50, 60-year-old one who suffer with mental illness, have alcoholism, drug abuse. Think about the lost human potential, for we didn't recognize really what was going on, not a mental health issue, gender identity disorder. We might see the lost lives, what we have later on. If we start to listen, open our doors, use harm reduction, you might make the difference, and you might save a life. Think about that. Thanks.